yeah, so yeah, just for your record, I will be recording today's session. And if you have any questions or anything, I can answer that at the end of the session. So is there any one of you who's attending the session for the first time? Please let me know. Either you can raise your hand or you can unmute and let me know. But if you have already attended my previous 3 sessions, then I will not be going through some of the slides. So let me know if you are new to the session, please. You can write in the chat box or raise your hand. Okay, so Sahar is new. Anyone else who's joining for the first time? Okay, so there are a couple of people who are joining for the first time. So I will quickly, go through my older slides, which are a part of the introduction. And do any of you have any idea like what is NAC? Or I can just give you a quick review of what is NAC and how does it work. So uh, first of all, a little bit about today's session. So today I will be reviewing some counseling skills when it comes to urinary incontinence. Let me start just 1 second. Okay. So today's objective would be a brief overview of NAC, and then we will be discussing a scenario of urinary incontinence in relation to NAC OSCE oriented counseling. A little bit about me. I'm an IMG just like you guys, and I started my journey of Canadian exams in 2021. Since then, it has been a bittersweet journey. From past 1 year, I have been working as a volunteer physician assistant with one of the family physicians here in Calgary, Canada. And other than that, I 2 years back, I had the chance to represent the problems which are faced by IMGs in their pathway to license to the health minister of Alberta at that time, Mr. Jason Coping. So I was a part of the delegation who could go there, and I represented some of the problems that we are having and the hurdles which are in our pathway. And that gave me this, idea and insight that I should be interacting with the broader audience. And that is the reason that I started this journey. So other than that, I have some experience of teaching undergrad students back home, and I have been a part of some volunteer organizations here in Calgary. Now, this was a little introduction about myself and what is NAC. As we all know, NAC stands for National Assessment Collaboration. So what do we mean by that? By that, we mean that, on that particular day, all the students who are appearing with you, all the IMGs who are in that particular exam, they are facing the same set of questions, okay, throughout Canada. So that means that in this exam, you really have to perform in a different way so that you can set up a mark in order to perform really well as compared to the people who are going before and the people who are coming after you, because you are going to set your mark. Everybody will be facing the same set of scenarios. They will be dealing with the same set of patients. So the way you tackle your patient, that is going to decide that, how to ace that exam, how will you are going to get some good marks in that exam. Therefore, your performance in those 8 to 11 minutes inside the room, there is no turning back after that. Whatever you have performed, once you are inside the room, once the buzzer rings, you leave the room, that performance stays with the examiner and with the SP, the standardized patient who's there. So you have to be very crisp when it comes to NAC OSCE. You have to be very crisp in your approach. It's not like we want that if you have chosen a wrong answer or you are, having some second thoughts, you can just flag that answer and then come back. NAC OSCE requires a very crisp approach. It's not like we want, it's not very theoretical exam, but it tests you on other levels, like how is your treatment with the patient and how you are developing that doctor patient relationship. And we as IMGs, we really struggle with that part of our training because we are not trained to that extent. Our bedside techniques might be really good, like we really know how to do a good examination, and because in back home in our countries, we rely a lot on physical exam, right? But when it comes to bedside manners, we really struggle with that. What kind of words are to be used? What kind of words are not to be used? When do we need to stop? What kind of information we need to provide? So NAC OSCE is basically a test of all those things, that whatever you're telling the patient, how are you interacting with that patient in in the Canadian system and according to the Canadian ethics. So basically, NAC OSCE is like a training program that trains your character and the way you talk to the patient and to deal with the patient. So this half-day exam has 12 stations. 2 of them are pilot stations, and those 2 pilot station means that your performance on those 2 stations will not be counted towards your final score. But the sad part is that we don't know that what 2 of those stations are. So basically, you are performing on those 12 stations in that one day, and you are just running with the clock. And in that scenario, your time is your biggest friend, and your time is your biggest enemy as well. So you have total 11 minutes. How is the time breakdown for that? The time breakdown is that you have, people say you have 2 minutes outside the room, but I say you have 1.5 minutes. Why do I say that? Because 30 seconds are just wasted when you are going from one door to the other door. So in those 1.5 minutes, you have to decide your goal that, okay, now I'm entering this room and this is the statement that I've gotten on the main page. And what would be my goal? What am I supposed to do once I'm inside the room? So these 1.5 minutes are very critical for you to set up your goal and plan and organize your next step. So what you need to do in this 1.5 minute, you have to write your basic history template. You have to write your task, like whatever question is there and whatever they're asking you for. For example, if it's a history station, it's a history and physical exam, or is it a counseling station? So you have to write that down quickly. And other than that, your basic history template. By basic history template, I mean that the basic history of presenting illness and past medical family history, whatever you're going to ask. And once you read the stem, the moment you see that, oh, it's a female, quickly you have to write that I have to write the MGOS, which is the mnemonic for the gynecological history that I'll be discussing today in today's session. Other than that, if it's a peds patient, then there is another mnemonic for that. If it's a teenager, it's another mnemonic, that what points of history you cannot miss. So this is how you are going to plan that 1.5 minute outside the door. Now, what do NAC OSCE question stems usually look like? Okay, in my view, in NAC OSCE, you can have 4 types of question stems. It can be history and physical examination. It can be history and counseling. It can be history only, or it can be examination only. Usually in the history and physical exam part, you can have a post encounter. And even with history only, sometimes you might have a post encounter. By post encounter, it means that after you're done with 8 minutes of history taking and examination, there will be 3 minutes in which you will be asked 2 to 3 questions. Usually it's 3 questions. And in those 3 questions, the examiner will ask you, any 3 questions, you have to give the answers, and you have to be very, very crisp in those answers. Because if your buzzer rings and you miss your question, he will not ask the third question. You will not get the time to wait there. So if you are stuck on question 1, if you don't know the answer, you will not waste your time on that. If you are, thinking and you're trying to make out the answer, you're trying to, think that what can I do in this? There's a high chance you will miss your next set of questions. So time is very important. Timed answers are very important. So that's why this NAC OSCE is all about your practice. You have to practice your words. You have to practice how you will talk to the patient. It's just like learning a script. While working in a drama, So you need to have a very crisp script which should be timed, because in those 8 minutes, it's not only you who's talking. The SP is going to give you the answers. You will ask the question again. There might be some scenario in which the SP needs some time, if it's an emotional station and it's like breaking bad news or something. So, the SP might need some time to just cry or, do all that. So you need to manage your time very effectively when it comes to NAC OSCE, because you need to complete your important points. Okay, so we talked about time division. As I mentioned, 1.5 minutes for writing the template, 4 minutes for history examination or history counseling, and then post encounter. Now, let's practice this scenario together. Okay, my previous 3 lectures, they were on chest pain, GERD related to chest pain, and then GERD counseling related to that. I have recorded those sessions, and I will uploading the videos also. I will be sending the link on my Telegram channel in order for you to see that. Okay, so our today's scenario is that 60-year-old Rebecca Williams comes to your clinic to discuss a few concerns. Address her concerns and advise accordingly. Now, looking at this scenario, what do you think? What kind of a question stem is this based on the previous slide, this one? What do you think? You can write in the chat box as well. That what kind of question stem is this? Is it history and physical? Is it history only? Is it history and counseling? So what kind of a station is this? What this station is asking you to do? You can write in the chat box and then I'll quickly proceed forward. Okay, so okay, I haven't gotten any response in the chat box. History and counseling. Yes, exactly. Yes, it's a history and counseling station. So quickly, when you're outside the room in your 1.5 minute, you're going to make your list of differential diagnosis. You will be writing your task on the side of your notebook. You can quickly write the name of the patient as well, because you don't want to forget it once you're inside the room, and your basic history template. What would that be? Your history of presenting illness, past medical history, family history. Usually I use a mnemonic for that, and I will be discussing that in another session. But let me give you guys like 30 seconds. It's 7:14 right now. So let's take 1 minute, 7:15, and I would like you to make a list of your differential diagnosis before we proceed further, considering this scenario that she comes to you and she has a few concerns. Okay, this is the template that you have read outside. Okay, just to give you an idea and make it more clear, uh, because we are not doing it in the formal history method, it is a station of urinary incontinence. So keeping in view urinary incontinence in a 60-year-old female, what would be your differential diagnosis when you are outside the room? So I'll be giving you almost a minute now. Okay, so all right. Okay, so now if anyone can you write in the chat box, or one of you can just open your mic and yeah. So we have stress incontinence, diabetes, UTI, prolapse, bladder, stroke. Very nice. Okay, anyone of you who would like to volunteer, open your mic and write it, or you can just write in the chat box. Okay, so we have this nice list of differential diagnosis. All right, let's proceed further. Now, so this is our practice scenario that outside, you can just have this scenario outside the room. Now, this is a very vague kind of a question. You don't know that inside the room what you're going to face, okay? So it's a 60-year-old Rebecca Williams, and she's coming to discuss a few concerns. So now you know that it is your counseling station, so you can just write counseling points if you're outside the room, because you don't know what you're going to deal with when you are inside the room. Okay, let's go to the next slide. Whenever I make my list of differential diagnosis, I use a mnemonic, which is SPIT. What do we mean by SPIT? SPIT means that your list of differential diagnosis has to have a serious diagnosis, a probable diagnosis, an interesting one, and a testable or a treatable one. Like this, if you keep in mind that you need to have a comprehensive list of differential diagnoses, you will not miss anything once you are inside the room. Because if your differential diagnosis is very narrow, you can miss easily, anything which is important. So whenever for NAC OSCE, I'm making a differential diagnosis, I will keep this mnemonic in mind, that my list of differential diagnosis has to has, a few different ingredients from here and there. Other than that, the important thing to remember while making a differential diagnosis is that you have to include the system which is being asked in the question, and think of some adjacent, at least differential diagnosis from 2 or 3 other systems. So for example, this is a nephrology station because I told you that it's urinary incontinence. So in regard to that, you have to make your, what could be, your serious diagnosis. Serious means something which is life-threatening, maybe a carcinoma. Okay, something which is most probable, which can be, in a 60-year-old, it can be stress incontinence, urge incontinence, or a bladder prolapse and stuff like that. Something interesting, something treatable. So keep these things in mind when you are making your list of diagnoses. Now, keeping all this in mind, this is my list of differential diagnosis, that it can be a UTI, okay, something very common. It can be stress incontinence, urge incontinence. It can be a new onset diabetes. It can be normal pressure hydrocephalus. It can be atrophic vaginitis. It can be just a simple stool impaction considering her age. It can be a malignancy, and it can be due to any drugs. For example, some of the diuretics or antidepressants that can, lead to all these things. So you have to make a very comprehensive list of differential diagnosis, and then you have to narrow down your differential diagnosis once you are inside the room by asking some questions to the patient. Now, let's go to the next one. Okay, so these are the points, okay, when it comes to this station, that what are we supposed to ask in history of presenting illness. So I would like to ask the onset to the patient, the course of the disease, the duration, and the impact. So it is OCD. The mnemonic is OCD for this. O is onset, that you will ask the patient first. So now how are you going to proceed with this station? You will enter the room. We will ask the patient that, knock, knock, enter the room and say, good morning or good evening. I'm Dr. Umar. I'm your physician for today. May I please confirm your name and age? And then the patient tells you their name and age. And then you ask the patient, how would you like to be addressed? And the patient says, okay, you can call me Rebecca. So just on the corner of your page, quickly write Rebecca, because you don't want to mess up her name. While talking to her, you might need to say her name a couple of times. So you don't want to, mess up. And you are dealing with 12 stations on that day. It is very easy that you will mess up the name. So just quickly write on the page, because it is very sensitive if you mess up the name, or if you mispronounce it, or if you just forget about it. So it's very important. So just write the name, that, okay, it's Rebecca. So Rebecca, what brings you in today? Because the question was very vague, that she has some concerns. So just ask an open-ended question. Okay, Rebecca, what brings you in today? And she tells you that, oh, doctor, I'm really embarrassed to share this, or she just tells you quickly that, I'm having this trouble that I'm leaking urine for the past, 6, 7, 8 months. And then you ask her, okay, is it the first time that, this episode has happened? And she might tell you, no, it has been going on for a while, but it was off and on, but now it is continuous. Then you ask her, okay, that since it has started, is it something that is making it better, something that makes it worse? All those history-taking questions, the duration, the timeline. So after that, you ask her, how is it impacting your life? So she might tell you, I'm so embarrassed, I cannot just go out. I cannot enjoy the usual activities that I was dealing with. And then you can ask her, so do you think you need help in that regard? You can do a quick depression screening at that stage as well, if you feel that the patient is really, really down because of that. So in the history of presenting illness, you will go with onset, course, duration. This will give you a brief idea that what the station is about, okay? Next part is that you assess for the urinary symptoms. Now, since it's a nephrology station, each system has different set of questions or cluster of symptoms that you need to discuss with the patient. This is a nephrology station. So for all the cases related to urinary infections or, incontinence, and whenever there's a nephrology station, you always have to have obstructive symptoms, irritative symptoms, and then you have to ask for a urine analysis. The mnemonic for urine analysis is COCA-B, and COCA-B we always use whenever there is a liquid. It can be vomiting, it can be blood, it can be anything. So whenever there is bleeding, vomiting, or urinary infection, any liquid is there, you will always use the mnemonic COCA-B. And what does that stand for? Color, odor, content, consistency, amount, presence of blood, any crystals, stuff like that. Okay. Now, what are the obstructive symptoms? So there are a set of questions that you have to ask for the obstructive symptoms: hesitancy, weak stream, incomplete emptying. So you can ask the patient, do you feel that there is a change in the urinary stream? So the patient might say, no, I think it's still the same. In fact, sometimes I feel that it has increased. She can give you any answer that she likes. Then you can ask her that, do you feel that you still need to use the toilet once you're done peeing? And she might say, oh, yeah, sometimes I do feel that the bladder is still full. Then ask the irritative symptoms, that do you feel that you have an increase in the frequency of urination? Yes or no can be the answer. You can ask her, do you think that, you wake up at night now? Do these symptoms wake you up at night? You have to wake up at night to pee. She might say, yeah. Okay, then you can also ask about urgency, that have you ever, leaked some urine while running towards the washroom? She might say, no, 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 it never happens to me. So usually what brings these signs and symptoms? Oh, when I'm coughing or I'm laughing, or, I was doing some weightlifting exercises and I noticed that, this is now going on for a while. Okay. Now you have asked the patient the irritative and obstructive symptoms, just to rule out what? Just to rule out that there is no, sign and symptoms of any obstruction are there. There is no mass in there. There is no UTI. There is no pain while passing urine. So there are a set of questions that you need to ask to rule out these sign and symptoms. Then you ask her for the urine. Okay, is there any blood in the urine? No. Have you ever seen any small particles or stones in the urine? No. Have you ever been diagnosed in the past with any renal stones? She will say, no, I have never, because this is the point where you can always bring the past medical history. If it is relevant to your question, you can ask it before reaching the past medical history. This will give the examiner the overview that, okay, this doctor knows what this doctor is talking about. So you will quickly ask, have you ever been diagnosed with renal stones in the past? No, no, doctor, I have never been, diagnosed with all that. So these are your associated symptoms. Now, these were the questions from the renal area of the body. Next slide involves local symptoms, because you always rule out the systems around that particular system that you're talking about. So what can be the local system? You can ask about the bowel habits. So do you have any constipation? Do you feel your stool is hard? Okay. Do you have any difficulty in passing stool? Do you have any hemorrhoids? Do you have any skin tags? Ask all these questions. Then there can be different reasons. For example, do you feel that you have recently gained weight? You want to rule out diabetes or any metabolic disorders. You can ask her that, do you have any issues with your gait and balance? Because you're thinking about normal pressure hydrocephalus. Is there some trouble with your memory? Then you ask all these questions just in order to, rule out that you are narrowing down your list of differential diagnosis. Okay. Now, you rule out constitutional symptoms like fever. Do you have any fever? Have you lost weight? Do you have any night sweats? Just to rule out any malignancy and give the examiner an impression that you are a safe doctor. You're making sure that your patient is not having all these things, okay? So you have to tell them that you are a safe doctor. You will not kill the patient. That is something very important that they're always looking for. Even if it's a simple case, always rule out the red flags. Okay, next part in this history, because she's a female, we will ask about MGOS. MGOS is your menstrual history, your gynecological history, obstetrical history, and sexual history. Now, when it comes to counseling, and all these things, they are also a risk factor for stress incontinence. Now, let's imagine that we have established the fact that the patient is having stress incontinence, okay? And she needs counseling on that station. Now, next is this MGOS part. And after that, we can just, ask her about her smoking and the social history, that what does she do for a living, her smoking and everything. Now, when it comes to counseling on these stations, everybody has a different style of counseling, okay? And one can choose whatever they feel good and confident about. But my style of counseling that I feel more comfortable is in the conversational counseling. And what is that counseling? That counseling is that you are asking something to the patient is replying back to you. Instead of just giving a long list of, lecture for 4 minutes, and you in between, you're just asking the patient that, oh, are you, feeling okay? Are you getting my point? Are you with me so far? No, I don't like those statements when you're doing counseling, because you're talking for 4 minutes and the patient is just lost. So what style of counseling I like is the conversational counseling. Okay, and how do we do that? So today's presentation is basically on that. Yesterday I did it for GERD, and today I will be doing it for stress incontinence. Okay, if any one of you would like to volunteer and do the counseling, these points, these are the points that I would like to discuss on the counseling station. So you can use this template or your own template. If we have a volunteer, I would love you to participate. But if you don't want to do that, that's fine. I can just, keep on talking, and you don't have to turn on your cameras for that. So let me know if any one of you would like to go ahead with counseling. You can raise your hand or just unmute yourself. Okay, so we don't have any volunteers. Nobody's raising hands. Okay, so I'll just go ahead with this then. Okay, so since it's a stress incontinence scenario, and when I have to do a counseling, I plan my counseling in a different way. So when we were discussing, let me go back a couple of slides. Okay, so yeah, so till this part, okay, this part, like the assessment of urinary symptoms, local symptoms, and then constitutional symptoms. This part I like to do in the history section, okay? And the moment I reach this part, from here, I start my counseling. And MGOS, which is also, the risk factor for developing stress incontinence, I include that in the counseling. So how do I do that? So I will, now we are done till this part, okay? That the patient is we have established the fact that the patient is having stress incontinence. She's leaking urine whenever she's coughing or sneezing or whatever, okay? Or lifting weights. So now I'll go ahead. Okay, Rebecca, thank you very much for providing me with this information. And now I will be asking you some more questions, just, to establish my diagnosis more clearly. So from whatever you've told me till now, I feel that you have a condition which is called stress incontinence. Do you have any idea what it is? And the patient says, I have an idea, or I don't have an idea, okay? It can go either way. So you just tell the patient, okay, so let me elaborate some more on it. So stress incontinence is that due to various reasons, your pelvic muscles get very weak with age, and there are certain risk factors for that make your pelvic muscles so weak that whenever they are under pressure, for example, if you're having constipation, if you're sneezing, or you are working out, so under that pressure, the pelvic muscles are unable to hold your bladder, and the bladder just leaks some urine. This is called stress incontinence, because when your body goes into stress due to any external factors under pressure, you just dribble a few drops of urine. And I know that this must be very frustrating for you, and it is impacting you because it is affecting your daily activities. So there are various factors which are responsible for that, okay? So let me tell you that, being a female, in our life, we go through a lot of changes. So I would like to know some more about your menstrual history. So at what stage of menstruation are you? When was your menopause? And she might say, it was 10 years back. Okay. And did you have any sign and symptoms like vaginal dryness or hot flashes? And she might say, oh yeah, I had some, vaginal dryness, and yeah, that happened. Okay. So there are certain other things, if we have had any gynecological procedures in the past in the pelvic area, for example, like DNC, miscarriages, that can also lead to, weakening of the pelvic muscles. And with age, it can lead to stress incontinence. So do you have any previous history of any gynecological procedures? No, doctor, I don't have that. Okay. Another factor which is responsible for causing the stress incontinence is, the number of parity, that is the number of kids that that you have. So may I know that how many children do you have? Okay, I have 6 children, doctor. Okay. And may I know what was the, mode of delivery? Oh yeah, they were all normal deliveries. So was it a spontaneous normal delivery, or did they ever have to put a forceps? Oh yeah, 2 of my kids were vacuum extracted, doctor. Okay, fine. And then now I will have to ask you a couple of questions related to your sexual history. And, let me just assure you that we ask these questions to everyone. And whatever we'll be discussing today, it will be confidential between you and me, unless it's a threat to you or anyone else. Okay. So how many sexual partners have you had in your entire life? And she might say, oh, in my young age, I had maybe 5 partners or 6 partners, but now I am in a monogamous relationship. Okay. So you had 5, 6 sexual partners. Have you ever had any sexually transmitted infections in the past? Oh yeah, I was treated once for them. Okay. So how about now? Any recent sexually transmitted infections? No, doctor, nothing now. But in the past I had. Okay. Did you ever had any inflammation in your pelvis area? We call it pelvic inflammatory disease. Have you ever heard of this term? No, doctor, I never had that. Okay. Thank you very much for answering my questions so far. There are some other factors which also, affect towards your stress incontinence, and they are your social habits. So do you smoke cigarettes? No, doctor, I don't smoke cigarettes. I used to smoke, but I have, I quit it a long time back. Okay, that's good to know. That is the best thing that you can do for yourself. So, Rebecca, sometimes, when we gain weight, that also puts that extra pressure. So do you feel that you have gained weight in the past? Yeah, doctor, I do feel that I have gained some weight. Okay. How many kilos? Have you ever measured that weight? Oh, yeah, I have, gained maybe 20 kgs in the past 10 years, especially after my menopause. Okay. So do you think you need any help regarding that managing of that weight? Yes, doctor, I might need that help. Okay, so I can, refer to a dietitian. We have some very good dietitians on board with us, and they can, customize a tailored plan for you according to your needs. So whenever you're ready after this appointment, I would like to set up a follow-up appointment to discuss your weight loss and how ready you are to lose weight. Is that okay with you, Rebecca? Yes, doctor, that's fine with me. Okay, then you go ahead with the next part and you educate the patient. How you educate the patient? You tell the patient that, okay, so Rebecca, till now we have discussed the risk factors, what could have caused this stress incontinence. Now let's have a look that, how it can be managed. So there are various methods of managing it. Some are lifestyle modifications, which are non-pharmacological or non-surgical methods. And if things don't get better, then there are surgical options as well. So in today's visit, I would like to emphasize more on the lifestyle modifications, because I feel that maybe this thing is still manageable, but if you are not able to manage it with lifestyle modifications in the next 3 months, I can always refer you to a pelvic floor clinic. Okay, doctor, that sounds good. So in lifestyle modification, the first thing that I would like to emphasize is your Kegel exercises. Do you have any idea what are Kegel exercises? Yeah, doctor, somebody told me in the past and I tried it for a couple of times, but I left it and all that. Okay, but I really want you to, emphasize on Kegel exercise. And if you can try that for 3 months, and how do you do that exercise? It's just like, holding your pelvic muscles for like 30 seconds and then just let it go, and do that for 3 times in a day. And let's start doing it for 3 months, because it's a lifestyle modification. And other than that, the dietitian on board with us will help you to reduce your weight. So both things can go hand in hand, your Kegel exercises and your weight loss. It will go hand in hand, and it will have a significant improvement of your sign and symptoms. Okay, doctor, but what if it doesn't improve? Yeah, if it doesn't improve in 3 months, I will definitely refer you to the pelvic floor clinic. Okay, doctor, sounds good. Other than that, we have to make sure that you are not constipated. So do you take enough fiber in your diet? Yes, doctor, I do take enough fiber. Do you drink enough water? Yes, I do drink enough water. Okay, that sounds good. And there are surgical options available as well. So if your sign and symptoms are not getting better, I can refer you to the pelvic floor surgery. Oh, doctor, that sounds good. Okay, Rebecca, thank you very much for answering all these questions. Do you have any concerns for me so far? So doctor, what kind of surgical options are there? Okay, so there are various surgical options. There are sling procedures, there are artificial sphincters. There are a lot of things which are there, but I'm not the expert, because the surgical team, they can guide you better in that regard. That is the reason I want you to be referred to them, okay, in case you don't get better with all these lifestyle modifications. Okay, doctor, that sounds good. So Rebecca, I would like to see you in 3 months from now. And if during in between these 3 months, if you ever feel that your symptoms are getting worse, if you notice any blood in your urine, if you feel that you're losing a lot of weight, or you feel that the nature of symptoms have changed, you get any sharp pelvic pain, please feel free to come back to the clinic, okay? And you can always go to the emergency department as well. If you cannot come, if you feel that the waiting time is in the clinic is long, you can always go back to the emergency department. Okay, so right now you have explained the patient about the sign symptoms, you have explained the patient that what your next steps would be, and you have explained to the patient that the red flags, that in case the symptoms get worse, she develops any bleeding, she can go back to the emergency department. And to close it up, you will just, wrap up the station properly, you will just say that, okay, Rebecca, whatever we have discussed, I have various pamphlets and I have some websites that I would like you to, give those to you, the brochures for your information. And if you ever feel down or depressed because of all this, there are certain groups, many online groups who have people who are dealing with similar situations, and they are very motivating. So if you want to be a part of any such group, just let me know and I can, look into that and I can find something for you if it's very distressing for you. Okay, doctor, is there something, doctor, that I can just use for the time being, because I like to do gym, I like to lift weights and all that. Yeah, there are certain things like which are called adult diapers or incontinence diapers, and you can use them if you feel that the situation is really bad. And but you just don't lock yourself in the room because of this, because everybody can go through this in their life at some point. So we are here to help you. Okay, Rebecca, thank you very much. And this is how you close your station. So now, till this point, you have explained everything to the patient, and because you discussed MGOS in the section of counseling, the patient also got a big chance to share her story. Any questions that we have so far, or any comments, please? So no comments, no questions? Okay, we have some. Okay, thank you. Anything that anyone would like to add to this? Okay, so since it's just, a counseling station that I have focused on today, but if it's a full station, if we do the entire case together, then we will do a lot of more things as well. There are a lot of other steps that we need to add to this history. So this is not a complete solution of this station, but this is mainly focused on counseling part. And in most of my classes, I just focus on the counseling part because I feel that as IMGs really struggle with that. Okay. So this was till here. Thank you very much, everyone, for listening to all this. Now I'll just quickly go to the next slide, which has the details about my bootcamp. So I'm offering a NAC OSCE course as well. The proposed date to start is from 7th of January till February 26th. I will be running 2 batches. In the two classes on weekday mornings, Tuesdays and Thursdays probably, and 2 classes on weekend mornings, and timings would be 9:30 to 12:30 on the weekdays, and on weekends it would be 11 to 2 Calgary time. Other than that, the fee for the entire course is 400, and I plan to cover 140 to 160 high yield topics. Number of students in each batch would not be more than 12. That's it, because I feel that then everybody doesn't get a chance to participate and it compromises on the quality. In my previous classes, I also gave a breakdown of the topics that I will be covering. I have not included that in today's presentation, but if you want, I can go through that quickly. These are the 16 classes, their breakdown, and the topics that I'll be going through. The systems are GI, RESP, cardio, uronephro, neuro, MSK, endo, peds, obs, gynae, and psychiatry. A lot of people asked me that if I'll be giving notes. So yes, I will be providing you with notes. Everything would be written on them. And I will also be providing you with the checklist like at the end of each system, once we complete GI system, I will be giving you a checklist that how you performed on your, I will be giving you scenarios as well, and I'll be giving you some checklists. Other than that, if you have any questions and concerns, you can reach me out at medicinebyheart@gmail.com. This is the link to my Telegram channel. And if anyone is interested in looking at the topics that I'll be covering, just let me know and I can pull out that slide and show it to you. So, yeah. So any tips, doctor, for time managing, as your counseling had took 10 minutes? Yeah. So, Kenna, this counseling took 10 minutes because I was doing it single-handedly like a lecture. But if we do it one-to-one, like I have done this similar counseling in my own exam in 4 minutes. So, because when you're talking to the SP, that is different. Like right now, it was like a lecture, and when you're doing it like a lecture, because I was the one giving you the answers, I was the one asking the questions, so I was playing both the roles. So this is very much manageable in 8 minutes, and I've done that. So so I'm very confident. The entire content that we have discussed, it is manageable. Yes, very much. I'm very confident about it. Yeah, because I've done it myself. So this is from my own exam experience, the notes and everything. Any other questions that we have? Anyone who would like to wear a watch? No, you are not allowed to wear a watch and or anything. And there is a clock in the room, but to be honest, there is no time to even look at that or even find it. There's a small clock somewhere in the room, but once you're inside the room, the things are so stressed that you don't want to look for time, and it stresses you out more if you're looking at the time and you're looking at what time it is and what's going on. So yeah. Telegram link in the chat, please. Oh, sure, I can do that. Let me pull out my Telegram channel. Yes. Okay, so someone asked me about my my score. So yes, I had 2 standard deviations above the mean. I had a very good score in NAC OSCE, and that is the reason I got kind of stuck with the Canadian exams, because I thought that if I'll not get a good score, I'll just leave this pathway. But I was fortunate enough to get a very good score. It was 2 standard deviations above the mean. At that time, the scoring was out of 1500, so I got 1426 marks. This is just for your personal satisfaction. So yeah, okay, yeah, I will post the Telegram link here in the chat. Just let me pull this out. Any other questions? If they're there, you can. Just 1 minute. Just need to copy it. Okay. So, Dr. Sukena, are you? Just 1 minute. I don't know how to copy this. Just yeah. I got it. Can't I copy this one? Just give me 1 second. I'll. So, Najla, the thing is that the 7th of January is the proposed date. Okay, I am thinking to push it 1 week further, and the reason is okay, I'm trying to push it 1 week further, and the reason is that a lot of people are coming back from vacations, and some of them have messaged me that schools are starting from 6th, so I might depending upon the students that I get, I might push it 1 week further. The only reason I wanted to start it from 7th of January was because the exam is in May and a lot of people want to start early. That was the only reason. From my side, it's not a problem at all. I can do that. Okay, somebody has asked me that if I have a course from QE1. No, okay, now the thing is that for QE1, I feel that it is unfair to charge IMGs for that. And the reason is, just 1 minute. Let me post. Okay, let me post the Telegram link here. Okay. So the link is here in the chat box. Okay. So I feel that, it's unfair to charge IMGs for QE1 because QE1 is very much an exam that needs your own effort. You have everything in the books. You don't need me to teach you. If I teach you, I sometimes just teach, like yesterday I taught a topic of schizophrenia. So I just teach that like that, but I don't think so that you need a paid course for QE1. It is not something that anyone can give you notes, okay? But you have to learn it by yourself. So just take a question bank, start doing questions, whatever topics are in that question bank, just write them on the side and re-revise them. So this is how you should prepare for QE1. That's why I have not done any course for QE1, because I feel that it is unfair that we ask the IMGs to pay for a QE1 course. This is very much our own effort. Yeah. If we work and can't attend, can we have recorded sessions? Yes. Yes, I will be recording everything. And I will be sending the recorded sessions to the students. That is my plan. I'm also working on one of the YouTube channels to make my own YouTube channel, and I will be uploading these free sessions on the YouTube channel as well, just for anyone to access. But if you cannot attend the workshop, the classes, yes, you will get the recordings. Yeah. And the other thing is that if you have enrolled for one course, for example, if you're enrolled for January and February, and for somehow you miss a class or two, if I'm running another batch, you're more than welcome to come and join that. The only thing would be that you will not be able to perform in that batch, because of course the batch which would be there, they will be performing. But you can always come back and tell me that Dr. Sana, we need a revision of maybe GI or something. So when are you having your next class? So I can just tell you that, with the next batch, we are having this class on this date. So just join us, and I can send you the link for that. So because I believe that it's all about learning, and it's all about working together. And I am an IMG as well. I know the struggles that we all go through. We are working, we have families, we have kids to raise. So I'm very flexible in that regard. Okay, anything else? Yeah, duration of course. So each set of course would be 2 months duration. That would be 16 classes. Okay. So in 16 classes, we will be covering the high yield topics, all the high yield topics. And we might, add a couple of classes, one or more, depending that how the batch is progressing. Because if you are not progressing and learning the way things should be, then we can add one or two more classes. Or if you feel that something needs more, of a comprehensive review, of course we can do that. But 16 classes are my target. 2 months, so that you also have time to practice your. Okay, so how to register? Yeah, you can shoot me an email at medicinebyheart@gmail.com, or just reach me out on Telegram. If you're on the Telegram channel, you can just shoot me a message on Telegram, and let me know that what is your preference. Are you interested on the weekday batch or the weekend batch? And then I can add you there. I'm just posting the Telegram channel link again. So you can join the Telegram channel, and you can just shoot me a message on that. Any other questions? Any other questions? Sorry, I just joined the fee structure. Yeah, so okay, I'll just show you the slide as well. The fee is 400 Canadian dollars for the entire course of 2 months per student. So let me go back to the presentation. Just 1 second. I can show you that slide also. Okay. So yeah, this is the detail that I plan to start from January 6th, but I might push it 1 week ahead. Like maybe we can start from the next weekend. And then we'll be having yeah, 2 batches, and timings would be these 2 days in a week. And this is the 400 Canadian dollars, the entire fee. And I plan to cover 140 to 160 high yield classes, and number of students would be 12 in each batch. If you guys want to see the breakdown of the topics, let me know, and I can share that with you as well in the chat. So Hina, I will be posting this video also on my channel. I will be updating you on that so that you can have a look. And I will be doing a couple of more free classes during this week. So you can join any one of them just to have an idea that what the classes would look like.